I'm a little embarrassed. I hadn't thought about what Mr. Smith said, that we're here talking about doubling the size of the federal budget, and here on the Budget Committee, we haven't passed a budget yet. I know it's tough to find 218 votes on one side of the aisle or the other, but I've said it before and I'll say it again. You're the right leader. Colonel Womack is the right leader to bring a bipartisan group together around a budget. Just seems silly that we're going to take over 1/6 of the American economy, and that takeover is going to be conducted by a government that can't even figure out how to pay its own bills year to year. But we can do it, we just haven't done it. Let me start, Mr. Hadley, I had the pleasure of being on the first Medicare for All hearing on the Rules Committee, and we learned there that Medicare for All abolishes all of the Medicare Advantage programs, which about half the seniors in my district take advantage of, so that Medicare for All means something for all, but you're going to lose access to Medicare Advantage. What you say in your report, if I'm reading it correctly, is thinking about utilization management as one of the cost containment procedures. You say it would impose new constraints on the choice of health care services for those who were previously enrolled in the Medicare fee-for-service program. Is that correct?
That's correct. You could have, using utilization management as a technique to control costs is an option for policymakers, and there are a variety of different strategies you could pursue, and we detail those in the report.
But our current Medicare beneficiaries, those who've been paying in through their entire life, payroll tax, largest tax that 85% of American families pay, folks today are not burdened by that constraint. Is that correct?
Correct. In general, most of Medicare is fee-for-service or voluntarily.
They've either opted into a plan that's going to go away even though they chose it, or they've stayed in general Medicare, which is also going to go away because they're not subject to those utilization procedures. You said something in response to a question earlier about improper payments. You said it would, the question was whether or not improper payments would be higher under a Medicare for All system. And you said it would depend, improper payments could be higher or lower than today, depending on the investment in fraud prevention. You all look at our numbers every year. Is it CBO's position that we have not yet reached the maximum utility of fraud prevention efforts in the Medicare system, that if we hired more fraud preventers, we would get more than a dollar-for-dollar return on that in today's system?
Yes, that's correct.
About how much elasticity is there? Where are we 10% short in fraud preventers? Are we 20% short? It just seems like among the things that we could all agree on, nobody wants to see improper payments go out the door. It's wasted resources.
I think Dr.
How short are we, Dr. King?
I don't have the exact numbers, but we're not that close to the threshold.
I would appreciate that if you could. You don't have to reinvent the wheel for me, but if you could point me in the direction after the hearing, I would love to try to build some bipartisan consensus on fixing that issue. I think that we could. The report says a single-payer system that collected comprehensive data on patients' use of healthcare services could potentially manage available resources more efficiently. That certainly makes sense. I don't think that was a radical conclusion. But what was surprising is you went on to say in the United States, public programs, those single-payer systems that we have today, have implemented few utilization management programs. Why do you think that is, that you have identified an area where we could do better, and yet in the programs where we have an opportunity to do better, run at the federal level, we're not doing that?
Well, so one of the reasons is, in general, we are still operating under fee-for-service in many areas, but also in order to have that degree of coordination, you need more providers talking with each other, and that means, one way to get there would be having a IT system with medical records that are completely interoperable. But that's not the only way. You could do it in some other ways. But I think the two main reasons are that so far we have chosen to do things as a fee-for-service, or we've struggled with our own systems.
Well, I'd point that out, Mr. Chairman. I think Mr. Hadley is right in our programs like Medicare, like Medicaid, that are single-payer systems. For whatever reason, the political folks who craft those programs, the policymakers, have chosen to keep them as fee-for-service systems, to not implement aggressive utilization management. We would have to implement aggressive utilization management to bring down costs in a Medicare for all single-payer system. I might I'd like to explore why it is that we've not done that in places that we could do that today to bring down costs. And if it's because the American people are adverse to it, perhaps we should learn that lesson first with a smaller pool before we expand it to a larger pool. I'm not sure you all changed anybody's mind today, but I believe that CBO makes it a point not to try to change anybody's mind and just provide good data. So thank you very much for doing that.